I'm Gayani DeSilva, and I am a child and adolescent psychiatrist and the current chief of psychiatry at the LA County Jails. And I went to medical school initially because I was really interested in facilitating access to care. And so I found my home at the jails, helping improve access to care. And thank you to Mercy for bringing us together, because I really think that the only way to improve access to care is for all of us to share our ideas and our work, and to talk and work together, breaking down those silos, and operationalizing the relationships that we make. So it's not just personal relationships, but it's really making that infrastructure so that there are no silos and there's an actual infrastructure, and it's not reliant on just people making connections to each other, but the institutions that we all work in have to work together. So I hope that we work together towards that, and this is one step towards that goal. So today I wanted to give you a sneak peek behind the bars, because I'm not sure how many of you have been to the jail or know what goes on at the LA County jails. So I just want to let you know that jails and prisons are two different entities. So jails are basically pre-sentencing. So the people who come to our jails have been on the street. Basically, they come straight from the street into jail. And so they're at a really high acuity level, both emotionally and physically. Their medical conditions and their psychiatric conditions can be quite acute, like in an emergency room. So jails are locally operated correctional facilities. They receive offenders after arrest and hold them for a short period of time. So the average length of stay in a jail is about 81 days or 86 days. They also hold them pending transfer to other facilities. Twin Towers is the largest mental health facility in the US. We'll talk a little bit more about that in the next slide. And what we do here at DHS in the jails is that we provide mental health services and medical services to everybody in the jail system. We do have several facilities. We've got Twin Towers, which is one of our largest facilities. We have CRDF, or Century Detention Facility, for the women. We have Men's Central Jail. We have Pitches Detention Center up in Castaic, and the North County Correctional Facility, which is also up there in Castaic. And we have all levels of care, and we have 2 LPS designated units. We have an inpatient unit, and we have a short-term inpatient unit that we just opened in June. Go to the next slide. So what's our scope of our population? Basically, we are the largest jail system in the country, in the world. We average about 13,000, almost 14,000 people at any given day. Last year, the early part of the year, we had almost 17,000 people. So we take care of a lot of people who are very, very sick. To give you some perspective, the next largest jail facility is Rikers Island in New York. And they only have like 6,000 or less than 6,000 people. So we're doing a lot of work at the LA County jails, and it poses a lot of challenges, but it also poses a great opportunity to do some really impactful work. And if we can do it in LA County, then there's no excuse for the rest of the country to be able to do it in their facilities. So we already talked about average length of stay. More than 6,000 patients a day are identified with mental health issues. A lot of the illnesses that we see, substance use is 61% of men, but there are actually more women with substance use disorders than the men. They're almost at 80%. And I thought this was kind of interesting that 60% of people, when they are arrested, are actually intoxicated. It's a big problem. Antisocial personality disorder, it's about 50% of men and about 13% of women. Schizophrenia is 2 to 3 times greater in the jail population than in the general community. There's a lot of people with post-traumatic stress disorder. I don't think 50% even touches it. I think it's closer to 80, 90% in terms of trauma. And then affective illnesses. Most common mental illness in jail is depression. And then the second to that is anxiety. Thank you. So the mental health care in the LA County jails, I want to give you an overview and a flow of our process. So we have all levels of care. We have outpatient levels of care and inpatient levels of care. We have about 55 psychiatrists. Our staff has grown in the last year and a half. When I first got there, we had like maybe 20-something psychiatrists, not all full-time. Now we have 8 supervising psychiatrists, at least 20 psychiatric nurse practitioners, psych techs, mental health nurses. We have therapists and psychologists at the jails. We do a lot of mental health care, and it's expanding and improving every day. I just onboarded 3 psychiatrists yesterday. And we have the 2 LPS designated units. We have about 33 beds in the inpatient unit. That's expanding to 41 beds at the end of May, hopefully, if we get all our beds in. And we have about 10 beds available at the acute intervention module. The acute intervention module is new. We started that in June of last year. In January, it's been operating pretty much as it's supposed to. It's an LPS designated unit for up to 3 days or 72 hours for rapid stabilization and treatment. So our flow, we start with the inmate reception center. So everybody who gets booked comes through the inmate reception center. They're assessed by nurses. We have a whole slew of nurses who do a screening for medical and mental health issues. And if anybody says yes to any of the mental health questions, they get punted over to the MH clinician. And if they need continuity of care for psychiatric care, like medication, the psychiatric team of psychiatrists and psychiatric nurse practitioners will see them. A year ago, only about 7% of people coming into the jails were getting a psychiatric evaluation. And then maybe about 50 to 60% were getting their medications bridged by nurses. There's a huge problem with continuity of care. And now we have, I'm really proud of this, now we have 100% of people who get a face-to-face evaluation within pretty much it's about 98% who get it within 24 hours, and then the other 3 to 5% get it within 5 days. But typically we're getting to see, most weeks we see everybody within about 48 hours. And so how did we do this? This is really an amazing feat in the jail. A few things, a lot of support from a lot of people, first of all, talking to everybody, talking to custody, talking to mental health, to medical administration, talking to the CEO's office, getting funding, and also taking a really honest look at our approach to mental health care in the jails. Whereas it used to be a very reactionary kind of approach to psychiatry and mental health care, mostly due to staffing issues, huge lack of staff. So the psychiatrists were kind of in this mode of just send me patients and I'll take care of them as I need to, if I can, and get to as many as we can. So what we did was we restaffed the IRC, just reallocated services, and then improved our numbers of staffing and utilized psychiatric nurse practitioners to help and build this team in the IRC so that we would be proactive. So the IRC psychiatric team is tasked with the responsibility, and they're held accountable for making sure that everybody gets that psychiatric evaluation and maintains that continuity of care, not just bridging medications, not just continuing medications, but really getting evaluated and assessed for what they need at that time. And this treatment plan that they develop and starting medications carries them through their stay at the jails. And we've seen this really make a big impact in the jails because overall acuity in general has decreased everywhere. So people are getting seen in the IRC, they're getting their medications, they're getting assessed, they're getting their treatment plan, they're getting their follow-up care scheduled, and this just really sets them up for much more stability as they go through the jail system. So the flow after they leave the IRC, they may go to their housing unit. So in the IRC, the mental health clinicians and the psychiatrists determine a level of care. So they determine if they could be in the general population or in the moderate acuity population or the high observation population. So those who are in the moderate to GP level general population, they go straight to housing from the IRC. But those who need a higher level of care or higher acuity, they go to what's called the supplemental assessment team units, where they get more treatment, more assessment from the mental health clinicians and from psychiatry. And then from there, once they're stabilized and their needs are even more clarified, they can go to their housing units. If anybody decompensates and they need inpatient level of care, they are assessed and can go to either the inpatient unit, or if they have not been taking their medications and they need just kind of a short stay, then they can go to the AIM, the acute intervention module. Most of Twin Towers is high level of observation. There are very few moderate units there. CRDF has all three. They have GP, moderate, and high observation. And then Pitches, and then the North facilities and MCJ do not have any high observation housing. So this is why Twin Towers is considered the largest mental health facility in the country. So there's a lot going on here at the jails. I haven't even gone through everything that we do. These are just kind of the levels of care, the acute care that we give. We do other things too, like we do a lot of education. We do trainings with custody. We do trainings with clinicians. We do trainings for the psychiatrists. We try to have both in-person and Zoom educational events. Sometimes they're 20 minutes long, like little TED Talks. Sometimes they're full-on psychiatric grand rounds. We do a lot of work trying to collaborate and integrate medicine, physical medicine with mental medicine. At all the facilities now, the primary care physicians and the psychiatrists do meet every month at least to share cases, share their pain points, and collaborate on care. So that's happened in the last year also. There's just a lot going on. So in February, we started the IRC, the Inmate Reception Center Psychiatric Team. They're doing fantastic now. We have several psychiatrists. We have several psychiatric nurse practitioners there. It's open and staffed 24 hours a day, so nobody falls through the cracks at any time during the week. In June, we opened the AIM that I told you about. And last year, we more than doubled our psychiatric staff. And this year, we have a lot of exciting plans, too. We're expanding the forensic inpatient unit. We hope to get to about 80 beds by the end of the year, or close to that. We are also developing an acute care program at the women's facility, which will include very close collaboration between the inpatient unit and units at CRDF, using a DBT kind of model and trauma-focused, trauma-informed care model. So we hope to have some dedicated beds at the inpatient unit and for this model where people can go and be medicated and be stabilized very quickly on the inpatient unit, but then come back to their DBT module at the women's facility. We're going to start there and hope to expand it, of course. The other thing that we're really interested in doing is not just thinking about how to improve care and continuity of care in the jail setting, but we do want to partner with the community, and so that there's continuity of care as people go into the jail, they get taken care of very well, and then also we want to ensure continuity of care when they leave the jail. So I personally will be looking to you in the next year and several months to build those partnerships and strengthen our collaboration so that we can ensure that all of our patients are taken very good care of.